And our last presentation, Oleg Yurievich Mamont of St. Petersburg, the use of multimodal approach towards treatment of malignant pleura.
Dear colleagues, I wanted also to share our experience in treating patients with mesothelioma, pleural mesothelioma. It was characterized by the median survival of 4 to 13 months for non-treated patients and from 6 to 18 months for treated patients. Flores reports that it was relapses were diagnosed with 63% patients. And so the treatment will be aimed at reducing the possibility for early death. There are no standards for surgery and practically no recommendations for chemotherapy and radiation therapy. Our idea was to improve the results of the treatment with malignant pleural mesothelioma. We tried to use multimodal approach. We had patients only with proven diagnosis with either epithelioid or biphasic morphological types, and response to any type of treatment is very poor. The survival rate is very low. From 2007 to 2015, we treated 17 patients. Combined treatment using multimodal approach. 15 patients had extrapleural pneumectomy. For some, this is the staging diagram. We had 7 cases. With surgery, we made the following technical difficulty. With standard access, we could not mobilize the diaphragm cupola. So the surgery was performed practically blindly, and we had to guarantee ourselves the second access. And that's why we decided also to develop the assessment guidelines and access to the rib and diaphragm sinuses. The depth here was 211 millimeters, and it was impossible to mobilize the whole pleura. With the access from the 8th gap between the ribs, we could find a better access. The depth becomes lower. However, the access is much more satisfactory, both tangentially and in depth. One of the stages was the removal of a part of the diaphragm and also removal of pericardium. We replaced the pericardium with a net, and that resulted in complications. In our case, it was heart tamponade. Now we're doing that with using the acryl thread. After removal of the pleura, we sensibilized the pleural cavity with phototidazine and radiclarine for 5 to 10 minutes, and The irradiation was at 500 joules. And hyperthermic chemoperfusion. We didn't drain the incision, but we use cytostatin and high dosage and combined it with hypothermia. In the course of chemoperfusion, there were no complications. Also, we had patients with the secondary pleural lesions. We also applied hyperthermic chemoperfusion, HITHOC. The problems arose because of the scope of intervention. We had one case of post-op death. The patient, the suture of the left atrium just parted. In another case, the death was registered on the 56th day because of the insufficiency or incompetence of the right main bronchus incompetence. 2-year survival rate for the patients who were treated with that multimodal approach was 41.1%. 21 patients in this reference group. The median survival was 18 months. In the reference group, 21 months. 2-year survival rate, 41%. We also studied the radiation therapy and polychemotherapy. It was administered to patients who had extrapleural pleurectomy, and with them, the survival, median survival was better. So this method, in our opinion, can be recommended after surgery. We tried also to examine various doses of the drugs. And if we used 200 millimeters per 1 square meter and 120 minutes of perfusion, the results were better for that group. So, because of that, we have developed the following recommendations. Very thorough hemostasis using argon and plasma coagulation. Plasty of the pericardial defect of a network of ligations to prevent intrapericardial hypertension. The hyperthermic perfusion of the pleural cavity should be done with the patient prone and turned to the side of the operation. Perfusate should be drained from the pleural cavity after chemoperfusion. And also during and after extrapleural pneumectomy, there should hydration should be performed, and also we recommend to perform extrapleural pneumectomy so that follow it up with a local control and radiation therapy. Multimodal approach using the cytoreduction and hyperthermal perfusion of the pleural cavity is a relatively safe method. 2 incisions, 2 thoracotomies in this treatment of patients has certain advantages over the standard method. The multimodal treatment in comparison with the conservative methods increases the time of relapse and median survival. Questions, please. A very interesting presentation. So you irradiate half of the thorax. Each case should be individually discussed with a radiologist. We have now an installation for modeling the pleural cavity, and we discuss it with our radiologist, and we are doing it together. Thank you. Now our program is exhausted. We have some time for discussions. Does anyone want to comment or speak? It looks like we were discussing a very sophisticated issue today, the pathology with a very tragic prognosis. The cancer of the esophagus and mesothelioma, pleural mesothelioma. Now we understand that though the reflux is one of the reasons, but we now find the cancer of the esophagus in the upper and in the middle parts of the esophagus among young women who have never smoked. This is another problem that we have become witnesses. However, now we have a very good method. This is submucosal dissection. And maybe if we combine it with a PT, we will be, if we could also assess the condition of the paraesophageal lymph nodes, we could apply submucosal dissection and the scope of the operation will be much smaller. So everything is here in favor of the submucosal dissection. Speaking about surgery of the second and the third stages of esophageal cancer, the parallels comparisons made by Sergei Yurievich of the stage and the size of the tumor were very interesting. How can we assess the depth of the invasion if the esophagus is stenotic? We cannot even reach